You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at the Dana-Farber Cancer Institute. Welcome to Season 2 of Medscape's In Discussion series on lung cancer. Today we'll discuss lung cancer diagnosis in young adults. First, let me introduce my guest, Dr. Julia Rotow. Dr. Rotow is a thoracic medical oncologist at the Dana-Farber Cancer Institute, where she additionally conducts clinical research in oncogene-driven lung cancer. Dr. Rotow, welcome to In Discussion.
Hi, Dr. Sands. Happy to be here today.
Dr. Rotow, I'd like to start out first with a bit about your career path. What was it that drove you into specifically around lung cancer treatment and lung cancer research? What brought you to this point in your career?
Yeah, that's a good question. I'm very lucky that I began working in the lung cancer field in the last 10 years, and that's been a time of immense transformation when we think about the treatment options available for patients with this diagnosis. So I've been fortunate to see the advent of both immunotherapy for our patients, as well as the really very rapid expansion of targeted therapy options. And that meant that lung cancer has become a very personalized disease when it comes to how we think about treatment. And that attracted me to the field in that I like being able to offer my patients individualized treatment options whenever possible. And that's, of course, what's also driven me to working in the field of oncogene-driven lung cancer.
Well, with that, let's dive in. We're going to focus specifically on lung cancer in young adults. And so this has really been an area of much more attention, I suspect in part due to, as you've described, the identification of targets and targeted therapies. So that'll, of course, be part of our discussion. But to start out with, how many people are diagnosed with lung cancer as young adults? Is this something that we're seeing changes in numbers? What's just some of the background of the prevalence of this diagnosis?
Yeah, when you imagine a lung cancer diagnosis, we often think of an older patient. And of course, our patients on average are closer to 70 years old at their diagnosis with this disease. But this isn't only a diagnosis of older populations, and we certainly do see this in young patients as well. It's less common, but as many as 10 to 15% will be under age 50 or even under age 40 or 30. So we do see this diagnosis in young patients. And perhaps concerningly, while for the general lung cancer population in the United States, we've seen declines in incidence of lung cancer, we're seeing less diagnoses. For younger patients, we've actually seen the reversed trend where we've seen increase in lung cancer incidence, for example, in patients under age of 40. And the reasons for this are not entirely clear, but it's something we're watching closely as we think about how can we think about finding and identifying these patients and treating them most effectively.
And you've described how this population is a bit different from what we think of classically. Classically, people are often surprised to find out that someone can get lung cancer without having any smoking history. And that's particularly a part of the discussion. We're talking about younger lung cancer diagnosis as well. Can you dive a little bit more into some of those aspects and how this may be different than what we see in the more classic, older population?
Yeah, for young patients, you're absolutely correct. This is a very different disease in many ways. These patients have different disease biology, and they are much more likely to have an absent history of tobacco use. And of course, not all patients with lung cancer will have a history of smoking. And in fact, up to 15 to 20% of the patients we see overall will have never smoked cigarettes. So it's important to know that while this is a risk factor, it's not required for a lung cancer diagnosis. This is especially critical for our young patients, where a very large number of them will often have never smoked. And this probably lends itself to a different disease biology, and we see different patterns of underlying driver mutations and different responsiveness to the available treatment options. And it also has implications when we think about lung cancer screening, where for maybe our more traditional patient population, we can focus on screening those patients with significant history of tobacco use. But for our younger patients, these sort of risk factors don't allow us to direct screening as effectively. And this really leads to the theme, I think, in lung cancer of this being a very heterogeneous disease, where it's likely many, many different subtypes of disease that all need very different management.
Yeah, these are some really important points I think you've touched on. So, first of all, the mention of lung screening, and I encourage the listeners to check out our prior episodes on lung screening, a super important topic in itself, but as you point out, not particularly relevant in this younger population that wouldn't qualify for screening. At the same time, there was some presentation at ASCO looking at genomic testing in the population of metastatic non-squamous diagnosis. So where it's certainly recommended, and showed that only about 50% of patients were getting that genomic testing. So surprisingly low numbers overall. And you've highlighted the importance of genomic testing in this younger population. Can you dive into that a little bit more as far as the background around the importance of that genomic testing?
Absolutely. I think some of the studies you referenced have looked at rates of successful completion of appropriate genomic-based biomarker testing for non-squamous non-small cell lung cancer patients. And you're absolutely correct. Look at the overall lung cancer population. Not all patients who are eligible for testing are getting that done. And that means they could be missing out on options for potentially highly effective and well-tolerated targeted therapy options, which we know can improve outcomes and improve survival and quality of life. So, for example, if you look at the broader non-squamous non-small cell lung cancer population, in whom almost all patients really should be getting this testing effectively, only about 85% would have any biomarkers at all in this study. And of those, only 50% had comprehensive next generation sequencing testing, which is our kind of definitive and recommended strategy to catch all actionable biomarkers. So this leads me to turn to the topic of health disparities, because while we see overall numbers of 50 to 85%, these differ among different racial and ethnic groups, for example. And this leads to differential access to effective therapies, differential access to clinical trials, and differential health outcomes. Dr. Bruno and her colleagues, for example, over the summer, published some great data looking at the Flatiron database, showing a 10% reduced chance of obtaining appropriate NGS testing at any time during treatment for patients who are African American compared to patients who are white. Again, this was associated with less access to targeted therapies and less access to clinical trial enrollment. And we think about getting all of our patients access to the most effective therapies possible. These sort of disparities are concerning. It shows that there's a lot of space to go, even using our existing set of knowledge to improve outcomes for patients if we can just apply it more evenly and more effectively to all patients.
Now, with that background in mind, does the patient age impact the types of biomarker testing that should be performed?
Absolutely. Our younger patients, and when I say younger, I'm really thinking patients under 50 or under 40 with lung cancer, have an increased probability of having an actionable genomic driving mutation. And this means one of the genomic mutations or fusions, which lends itself to treatment with a targeted therapy option. Right now, we have 9 such targets in lung cancer. We have the mutations in EGFR, BRAF, MET exon 14, KRAS, and also the fusions in ALK, ROS1, RET, and NTRK, all of which are actionable. And most recently, we also have HER2 activating mutations as a newly actionable target for this patient population. Many of these are enriched in our younger patient population or in our patient population without a history of tobacco use, particularly EGFR, ALK, ROS1, RET, NTRK, and HER2. I think a little differently about some of the other mutations like BRAF, MET, and KRAS, which are a little less predominant in the non-smoking patient population, but it just goes to show how critical getting this comprehensive testing is for our young patients. I would like to emphasize that comprehensive testing is important for all patients with non-squamous non-small cell lung cancer, regardless of their demographics. Historically, we might have focused only on these younger patients without tobacco use, but in modern practice, really all patients need comprehensive testing. But I'm especially mindful of getting those results as quickly as possible for my younger non-smoking patients.
Yeah, and this represents a field of just incredible progress. I think that many in the public are kind of under this impression that cancer care hasn't changed much in decades. And it's pretty remarkable looking back at the last 10 years in lung cancer care, as you highlighted from the very beginning, to see now that really almost everybody, with rare exceptions, in fact, in metastatic disease are getting a treatment that is new in the last 5 to 10 years, essentially, is pretty remarkable. And now within this younger population, as you've highlighted, these tend to have higher incidence of these actionable alterations and therefore are particularly benefiting from some of these advances. Now, one of the more recent advances is really the biomarker aspect. So being able to do this genomic testing from blood as well. So being able to get plasma and look at circulating tumor DNA is another way of then essentially looking for these alterations, and I think is increasingly being done. Are you doing a lot of ctDNA testing? Is that do you think about this differently in this younger population? How is this a part of your practice?
Yeah, and finding these drivers really is critical for these young patients. In our overall patient population, these more classically actionable drivers, you might expect to find in 20%, maybe now more 30% if you consider KRAS as our more newly actionable agent. But in young patients, in some series, you're seeing rates of up to 50 to 60%, or even in the highest rate I've seen is as high as greater than 80% might have something actionable you could find if they're particularly young. So, for example, in the young lung study, patients under age 40, they found over 80% rate of an actionable driver mutation. So it's really important to find these because, like you said, these lead to better outcomes. So the question is, how can you most effectively identify these mutations and these genomic fusions quickly? NGS is our gold standard, but it does take a little while, usually a couple of weeks to get those results back. And some patients, you can't wait that long, or most patients do want to get going on treatment as quickly as possible. Plasma NGS is a great new tool that allows us to do this testing in another way using liquid-based biopsy. You're looking for tumor DNA, which is shed into the blood and then can be used for sequencing. And it comes back much faster, often in as little as 7 to 10 days. So you can find out results more quickly, even in patients with small biopsies. However, it's less sensitive because it depends on disease burden and on tumor DNA shed into the blood. So in my own practice, I'll often use liquid biopsy or plasma testing as an adjunct to tissue-based testing. And certainly if I find a positive result, you can go forward with confidence and treat based on that. But I think the key point here is that a negative plasma test does not exclude an actionable mutation. In that case, having that tissue-based NGS testing is critical. Another novel technology, which is newly becoming available and is now commercially available as well, are RNA-based sequencing strategies. Traditional NGS testing that you might be using in practice is usually DNA-based, and that's great for most gene mutations, but is not as equally sensitive for all different forms of actionable drivers. And it's often a little less sensitive for gene fusions. RNA-based testing is optimized in part to identify gene fusions and can sometimes pick up actionable mutations that get missed by traditional NGS-based testing. And again, this particularly comes to mind to me when I am thinking about young lung cancer patients, especially patients under age 50, under age 40, where a negative NGS is a surprise because I expect to find something. In these patients, I will often go on to send RNA-based fusion-optimized testing. And we know that this can find new drivers that would have been missed. So there was a nice series out of Royal Sloan Kettering, which looked at their DNA NGS negative patients and showed that if you then went on to run a fusion-based test, about 14% would be positive for a potentially actionable alteration, usually fusions in ROS1, ALK, RET, or MET exon 14 splice site alterations. And if you looked at patients with low tumor mutations burdens, that probably enriches somewhat for our younger patients without tobacco history. They actually found almost 2/3 of patients could have an actionable fusion or other actionable driver found if they then obtain this RNA-based testing. So I'm now routinely incorporating this for my patients whom I feel are high risk to identify something. And I suspect the field is moving in the future towards doing this more broadly, just as NGS began to be used more broadly.
This is such an important point. I want to underline a bit of what you just said to make sure that all the listeners caught that. So essentially, you're describing that there's a higher prevalence of these actionable alterations, so the higher likelihood that these patients can get treated with targeted therapy. The risk is missing it. And so by doing the blood-based testing, sometimes, although it is fairly sensitive, there are plenty of cases in which we're missing that mutation or that alteration there. But further to that point is highlighting the fact that fusions can be missed even more so. And so by trying to get that, you're looking at RNA testing. Now, we discussed the ASCO data that said that only 50% of patients were being tested. The question then is, of those patients being tested, are they actually being adequately tested? And in this younger population where there is a higher prevalence of an actionable alteration is really making sure we're going to the full steps to detect that. And that RNA-based testing is a way of really particularly catching those fusions. Now, often when patients come in, they're anxious to get started on therapy. People really want to get going. They've been told they have cancer, and saying that they're going to have to wait for weeks to get this genomics back is often distressing. And so just for all of the oncologists out there, the sentence that I have found works best is when I describe to patients that I want to get them on the best therapy and not just the first therapy. People often say, oh, yeah, I want to be on the best therapy. But I also reassure them that if they're having a lot of symptoms or if things are getting worse or I think we need to start urgently, then I'll get them started on the first therapy while we wait for the results. But so my question to you is, one, if there's a sentence or a way of discussing this with patients that particularly works well for you, but also what is your first therapy? If you're waiting on genomics, what is your first therapy?
Yeah, it's a good point. And I like your phrasing, and I've used something along those lines as well, that we can always start standard therapy. You can always start chemo and get something started, but it's not personalized and it might not be the best, most effective, and best tolerated therapy for their individual disease. So I think focusing on patients getting the best therapy, not the first therapy, is a great way to word it. Now, sometimes you're right, we just can't wait, and patients need a result now or they need to start treatment now. And in that case, I try to start out with just regular platinum doublet chemotherapy. It can work quickly and it can temporize and alleviate some symptoms of disease while waiting on genomic testing results. And I frame it to patients as simply not committing us to any single direction, but simply getting things started while we wait for all their biomarkers so we can tailor their treatment to be more specific to them and hopefully as effective as possible for them. This leads to a really important point for young patients, which is, I think, the pitfall that sometimes can be present of immunotherapy for this patient population. Immunotherapy, we didn't talk a lot about it today yet, but it's the other big advance in lung cancer management in the last 5 years. And this has been transforming outcomes for many of our patients. And certainly our young patients can also benefit from immunotherapy, and it can play an important role in many of these patients' treatment. But in a patient with some of these classically non-smoking associated drivers, we know that the likely benefit of immunotherapy, at least as monotherapy, is likely much less. This has been shown in some retrospective series, like a very nice series out of the Immunotarget Registry, showing quite low response rates for patients with some of these classic drivers like EGFR ALK, ROS1 RET, in retrospective fashion when they're given a checkpoint inhibitor immunotherapy alone. And even in some prospective studies, there's been some very low response rates shown, as low as 0.5% to these sort of agents. So I don't like to end up starting out with immunotherapy monotherapy in this patient population, number one, because of concerns about efficacy. And two, I also worry about potential risk for increased toxicities if I have to transition a patient from an immunotherapy-based regimen, if say they get that dose while waiting on genomics, and then find an actionable driver and need to switch to a targeted therapy. Immunotherapy is very effective, but it's also long-lasting in circulation. So once patients get a dose, those antibodies and their effect are present for many months. And because of some of the combination-based toxicities when giving TKIs plus immunotherapy in combination, I try not to be in a situation where I need to transition a patient directly from an immunotherapy agent to a targeted therapy. Now, this risk likely varies from therapy to therapy, and it's probably best established for agents like osimertinib for EGFR-based lung cancer, where we can see increased risks of toxicities like pneumonitis. And for some of the ALK inhibitors, we see increased risks of hepatitis. So this is another situation where I'm talking to patients about it. I say, well, I want to give you the most effective therapy, and I don't want to increase the risk of that most effective therapy if we need to transition. And starting with a platinum doublet, again, gives us that flexibility to change treatment without driving up the patient's risk. So I'll do it cycle one if I really need to get started on treatment. I'd also like to highlight that the definition of complete genomic testing changes over time. So for example, a few years ago, it might not have included RET fusions or might not have included HER2 mutations. So if you're doing single gene testing, you'll be missing that information as new targets become available. And getting NGS-based testing tends to cover both existing and emerging targets more effectively and gives you a better chance to be able to look back retrospectively and find those newly actionable targets.
Yeah, that's such an important point. I have a patient who, at the time of initial diagnosis, had gotten the appropriate genomic testing for the targets that were available at that time. But unfortunately, in her case, actually got the full panel. Now, I had ended up putting her on hospice, unfortunately. And then within the week after doing that, was informed of a phase 1 trial that we were opening. And it was one of the RET targeted therapies. So we had the selpercatinib study, and she was one of the first people to go on this phase 1 trial because I called her a couple days after we had that last visit and said, hey, actually we have a study that's going to be opening very soon, and it looks like from your prior genomic testing you actually qualify for this study. And she fortunately had 2 years of disease control with further improvement in her quality of life and a very well tolerated targeted therapy. And another patient who had gotten the appropriate genomic testing, but it was not the full panel, who then, when I saw him at progression, realized that and ended up getting a full NGS panel. And he actually had a BRAF V600E mutation and ended up going on targeted therapy. This is some years back, but we now have the most recent example of KRAS G12C that you've highlighted, where I think KRAS testing was pretty common, even though there wasn't a targeted option. And now HER2 being one that maybe, just for our listeners, if you have patients that got full genomic testing that was for all available actionable alterations at the time of initial diagnosis, they might not have the full testing for what is available now. And so that's a really good point, that this is important to really look back at patients that were previously diagnosed. Now, I also wanted to highlight, this risk of targeted therapy plus immunotherapy, and particularly pneumonitis, hence the reason to start with chemotherapy alone. You described that well, but again, I want to highlight that too, because I think this is such an important point in starting with chemo. Hold off on immunotherapy until you get the genomic testing back. If you really need to start treatment, then just the chemotherapy. Now, everything we've discussed is really in the setting of metastatic disease. But of course, there's a lot going on now in early stage disease as well. We saw an approval in early stage disease that maybe you can dive into for us, as well as multiple ongoing studies now in the early stage space. What are your thoughts on what's going on in that area of the field?
Yeah, and until recently, a lot of the advances we've spoken about, immunotherapy, targeted therapy, more personalized therapy, primarily applied to metastatic disease. Then the trend in the last year or two, we're now seeing a lot of those advances being moved into the earlier stage setting and being applied in that area. That includes the use of targeted therapy and immunotherapy, but also the need for biomarker testing in earlier stage disease. So a few years ago, we saw the approval of adjuvant EGFR TKI therapy with osimertinib for resected EGFR positive disease. So now really all of our early stage adenocarcinoma patients having surgical resection need at minimum EGFR mutation testing. And in a young patient, given what I talked about before and the high prevalence of other actionable drivers, if I can access it, I try to get NGS testing in these patients. Though it's not yet mandated by standard of care, I think we're going to need it in the future. And also the movement of immunotherapy into that early stage setting in neoadjuvant setting and adjuvant setting, which now means that most of our surgically resectable patients also need PD-L1 testing. So again, those metastatic disease-based biomarkers are now being used for our resectable patients. And this lends itself to a little pitfall again with that use of immunotherapy in the perioperative setting in early stage disease when you might not yet have full comprehensive genomics. Just as in the metastatic setting, I don't like to use perioperative immunotherapy in our patients with these classic non-smoking associated drivers. And this is extrapolating from data in the metastatic setting, discussing potential for risk, potential for harm, lower potential for benefit. And I'm very open with patients when I have these conversations about what we know and what we don't know in this space. But because of this, again, getting those biomarkers, if possible, before giving that perioperative immunotherapy is also helpful. I've certainly seen patients who've been in a situation where maybe they didn't have their genomics in the early stage setting. They went and got their immunotherapy either right before or right after surgery. And then, as unfortunately is sometimes seen, had early disease relapse and were found to have actionable drivers. And now we're in a challenging situation where maybe I find that EGFR mutation, but the patient's just been on their adjuvant atezolizumab post-op, which we're now using for many of our patients. And I don't want to transition straight over. So again, I want to avoid that situation by getting biomarker testing up front, even in these early stage patients. Dr. Sands, you brought up another, I think, really important point in your last comment about clinical trials. Our young patient population is often seeking, one, more aggressive disease, and two, they're often very healthy without as many medical comorbidities as our broader lung cancer population. So they're often very good candidates for clinical trials and often very interested in finding clinical trials if possible. So I would encourage for these young patients, if they can be seen at a tertiary care center to explore trial options, that can be a great option for them.
There is so much to discuss in the diagnosis of lung cancer in our younger population, but unfortunately, that is all the time we have for today. Thank you for tuning in. If you haven't done so already, take a moment to download the Medscape mobile app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on lung cancer.